Usually when we talk about a medical diagnosis, there's this expectation of precision.
Oh, absolutely. It's almost like engineering.
Right. Like if you fall and break your arm, the X-ray shows that jagged white line against the black background, and the doctor just points at it. They just say, there it is, broken.
Yeah, it's a binary system. I mean, the bone is whole or it is fractured. And, that visibility is incredibly comforting for a patient. We're sort of hardwired to want our threats categorized and visible.
But then you step into the world of pediatric cardiology.
Right.
Specifically into this realm where a child heart comes under siege from profound systemic inflammation or is suddenly betrayed by a hidden genetic code. And suddenly that clean binary X-ray machine is it's utterly useless.
It really is. We're looking at a diagnostic landscape that is entirely murky.
Exactly. So today we're taking you, our listener, through what is basically a crash course in pediatric cardiology.
A very deep dive.
Yeah. We are going to comprehensively explore what happens when a toddler's heart is attacked by their own immune system and what happens when the literal architecture of the heart muscle is flawed from birth.
Which is the absolute definition of diagnostic muddy waters. But, it's also a masterclass in human biology.
How so?
Well, when you break down the underlying mechanisms, when you stop looking at just the surface symptoms and really dig into the why and the how, at a cellular level, a very logical, albeit sometimes tragic, biological narrative emerges.
And that is our exact mission today. We're going to look at two distinct but equally critical areas.
Right.
First, Kawasaki disease, which is this wild, rapidly moving inflammatory condition that essentially torches the heart supply lines.
It really does.
And from there, we'll move into pediatric cardiomyopathies. And these aren't attacks from the outside. They're structural failures of the heart muscle itself, specifically the hypertrophic, restrictive, and dilated forms.
And to really grasp this, it requires a complete shift in how we normally perceive heart disease.
Because we're conditioned to view heart disease as an adult problem, right?
Exactly.
Like the image we all have is clogged arteries resulting from decades of a bad diet, smoking, chronic high cholesterol. It's a slow accumulation of damage.
Yeah, a lifelong process.
But today, we are talking about infants, toddlers. These are pristine hearts that haven't had the time to build up atherosclerotic plaques.
And that distinction is paramount. I mean, in adults, cardiovascular disease is largely acquired over a lifetime of environmental exposures and lifestyle choices. The pathology is a slow decline.
Right.
But in children, the pathology we're discussing today is acute. It is sudden, it is explosive, and it is overwhelmingly systemic. The heart isn't slowly failing, it is actively under attack.
Yeah.
And to understand the first major threat, Kawasaki disease, we really have to start by looking at the heart's plumbing.
Okay, the coronary arteries. These are the critical vessels that wrap around the outside of the heart, feeding the actual cardiac muscle tissue with oxygen-rich blood.
Right, exactly.
If the heart is a pumping station, the coronary arteries are the dedicated power lines keeping the station running.
That's a great way to put it.
And in Kawasaki disease, those power lines are suddenly targeted and dismantled by the body's own immune system. So where did we even first document this kind of friendly fire?
It's actually a relatively recent discovery in the grand timeline of medicine. It was first described in Japan in 1967 by a pediatrician named Dr. Tomisaku Kawasaki.
Okay.
He was working in a Red Cross hospital in Tokyo and began observing a very strange, very specific cluster of children presenting with a constellation of symptoms that just didn't fit any known textbook.
What were they seeing?
They had these unyielding, high fevers, diffuse rashes all over their bodies, intensely red eyes, and swollen lymph nodes in their necks.
Initially, didn't he call it something far less intimidating,
Yeah.
like mucocutaneous lymph node syndrome?
He did, yes.
Which, to be honest, sounds like a bad rash and some swollen glands. It sounds like something you just sleep off.
Right, and that was actually the prevailing thought for a brief period. The medical community initially categorized it as a benign, self-limiting viral illness.
Okay.
These children would become incredibly sick, endure these raging fevers, their skin would literally peel off, but then eventually the fever would break. They appeared to recover.
The crisis seemed to pass.
Exactly. But then a terrifying pattern began to emerge in the months following that apparent recovery.
The tragedy struck.
Yes.
Yeah.
Dr. Kawasaki and his colleagues began to see some of these children who seemed to be entirely on the mend, suddenly collapsing and dying.
Oh my God.
And when pathologists performed autopsies, the findings were shocking. They found complete thrombotic occlusion of coronary artery aneurysms.
Let me translate that because the reality is horrifying.
Hmm.
The blood vessels feeding the heart had ballooned out, and massive blood clots had formed inside those balloons, completely blocking the flow of blood.
Yes.
So these toddlers were dying from sudden massive myocardial infarctions, heart attacks.
Exactly. Heart attacks in 2-year-olds. It fundamentally changed how the medical world viewed this benign syndrome. It became an urgent race to understand who was vulnerable.
So let's look at the epidemiology. Who is in the crosshairs here?
It primarily strikes the very young. About 85 to 90% of all Kawasaki disease cases occur in children under the age of 5.
Under 5. Wow.
Yeah. In the United States, the peak age of onset is between 18 and 24 months. Interestingly, in Japan, the peak is even younger, striking most frequently between 6 and 12 months of age.
And there's a massive geographic and ethnic disparity here too, right?
Yeah.
Japan isn't just where it was discovered, it's the epicenter.
It is. It's heavily concentrated in children of Asian descent, particularly in Japan, Taiwan, and Korea. Japan sees the highest incidence globally by a massive margin, with around 5,000 to 6,000 new cases diagnosed every single year.
That's a lot of kids.
It really is. But it's crucial to understand that it is a global disease. It affects African American, Hispanic, and Caucasian children as well, just at lower rates. There is also a distinct sex predisposition. Boys are affected more frequently than girls, at a ratio of roughly 1.5 to 1. And tragically, complications and fatal outcomes are also statistically more common in boys.
Okay, if we have this much demographic data, if we know exactly who is getting it and at what age, we must have pinned down the trigger. What is the bug? Like, what actually causes Kawasaki disease?
And this is one of the most frustrating aspects of modern pediatrics. Despite over half a century of intense global research since Dr. Kawasaki's initial paper, the exact etiology, the root cause, remains a complete mystery.
You're kidding.
No, I mean, it is widely, almost universally believed to be triggered by an infectious agent, but no single definitive pathogen has ever been caught red-handed.
Wait, hold on. We can sequence the human genome, we can spot a virus from across the globe, but we don't know what causes a disease that gives toddlers heart attacks.
I know, it's wild. But we do have a very long list of prime suspects. Researchers have isolated various viruses in these patients: parvovirus B19, adenovirus, rotavirus, measles, the Epstein-Barr virus. They've looked at bacterial culprits like meningococcal septicemia, mycoplasma pneumonia, and Klebsiella. There have even been deep dives into tick-borne diseases like rickettsia or bacteria carried by dust mites.
That's a lot of suspects.
It is. And the clinical presentation, the sudden onset of high fever, the diffuse rash, the swollen lymph nodes, it screams classic infectious disease.
Right.
Furthermore, it very rarely affects infants under 3 months of age, which strongly suggests those newborns are carrying protective maternal antibodies. And it's incredibly rare in adults, which implies that most of the population acquires immunity to whatever this trigger is during childhood.
But if it's a virus like adenovirus or rotavirus, wouldn't we see it behaving like a virus? You know,
Yeah.
one kid gets it at daycare, and 2 weeks later, half the toddler room has peeling hands and a fever. But we don't see those localized outbreaks.
That is the glaring contradiction that keeps epidemiologists up at night. We very rarely see clusters of Kawasaki disease spreading through a single family or a daycare setting in the way a highly contagious respiratory or gastrointestinal virus would.
So what's the running theory then?
This paradox brings us to the most heavily supported unifying theory. Kawasaki disease is the result of a genetic susceptibility that is detonated by an unknown, likely ubiquitous environmental factor.
So it's a genetic loaded gun, and an everyday environmental trigger just happens to pull it.
Precisely. The genetic evidence is robust. Siblings of an affected child have a 10 to 20 times greater probability of developing Kawasaki disease compared to the general population.
Oh, okay.
And if you look at monozygotic twins, identical twins who share the same DNA, they have a 13% concordance rate. That heavily points toward a genetic foundation.
Do we know what genes are involved?
Yeah, recent genome-wide association studies have identified polymorphisms or mutations in specific genes like the ITKPC gene, which plays a crucial role in regulating T cells. If a child has that specific genetic typo, their immune system is essentially primed to overreact.
Okay, so we have this unknown trigger, maybe just a common cold virus, that enters the body of a genetically susceptible child. The immune system doesn't just fight the virus, it goes rogue. It sets off a bomb.
Exactly.
Let's look at what that explosion actually does inside the body. Because the pathology here is a microscopic war. And it happens in three very distinct chronological phases.
It is a profound and highly destructive cascade. Kawasaki disease is, at its core, a vasculitis.
Meaning inflammation of the blood vessels.
Right. But it doesn't attack all blood vessels equally. It has a terrifying predilection for medium-sized arteries, most notably those coronary arteries we discussed. The actual mechanism of damage, the pathophysiology, unfolds over time.
Walk us through phase 1. This is the early phase. The child just spiked a fever. What is happening inside the coronary artery?
Phase 1 is termed the neutrophilic necrotizing phase. This occurs in the very first days of the illness. The endothelial cells, which form the smooth, non-stick inner lining of the blood vessels, and the vascular media, the middle muscular layer, become edematous.
They swell with fluid as the inflammation begins.
Exactly.
But at this early stage, the actual walls of the pipes are still holding together, right? They're swollen but intact.
Yes, the structural integrity remains. Neutrophils, which are the immune system's first responders, the shock troops of the immune army, rush into the area in massive numbers. They are trying to fight an infection, but they are attacking the vessel wall.
Okay.
However, during this first phase, a crucial structural boundary called the internal elastic lamina remains largely intact. It's angry, it's inflamed, but it hasn't ruptured.
The internal elastic lamina, that's basically the rebar in the concrete of the vessel wall.
Yes.
It's what gives the artery its snap, its elasticity, its ability to expand and contract under the high pressure of the blood pumping from the heart.
That is a perfect structural analogy. As long as the rebar holds, the vessel maintains its shape. But then we transition into phase 2, the subacute or chronic phase. This occurs roughly 7 to 9 days after the onset of the fever.
And this is where things get bad.
Very bad. This is where the pathology shifts from inflammation to outright destruction.
What changes? Do the shock troops get more aggressive?
The troops actually change entirely. The initial wave of neutrophils begins to die off and is replaced by a much more sophisticated, and in this case destructive, set of immune cells. CD8 plus T lymphocytes, IgA-producing plasma cells, and eosinophils.
And what do they do differently?
This second wave operates differently. They don't just cause swelling. They start secreting massive amounts of chemical signals called chemokines.
What kind of chemokines? What are they doing to the vessel?
They release potent inflammatory cytokines like tumor necrosis factor, TNF, vascular endothelial growth factor, VEGF, and specific enzymes called matrix metalloproteinases.
That's a mouthful.
It is. Think of these enzymes as molecular scissors. These chemicals directly target the architecture of the blood vessel and begin to actively fragment and dissolve that internal elastic lamina.
They're cutting the rebar.
Exactly, they are dissolving the rebar. When the internal elastic lamina fragments, the structural integrity of the vessel vanishes. Oh, wow.
Furthermore, the smooth muscle cells in the wall of the artery begin to die, a process called necrosis. So now you have a blood vessel that is physically weak, essentially turning to mush, but the heart is still forcefully pumping blood through it at high pressure.
So the weak wall can't withstand the pressure of the fluid inside it. It's like a weak spot on a bicycle tire tube.
Yes. It begins to balloon outward. This is precisely how the coronary aneurysms form. During this destructive subacute phase, they often form what are known as fusiform aneurysms, where the entire circumference of the blood vessel dilates and balloons outward, creating a massive, structurally compromised pocket.
So you have these fragile balloons forming right on the heart itself. That is the definition of a ticking time bomb.
It really is.
But the body doesn't just let it stay like that forever, right? It tries to heal. Which brings us to phase 3.
Phase 3 is the stenosis phase, and it unfolds over weeks to months. The acute immune attack burns out, and the body recognizes the massive structural damage to the arteries. It attempts to patch the weakened walls.
How does it do that? The aggressive inflammatory cells are gradually replaced by fibroblasts and myofibroblasts, which are cells that lay down scar tissue. Fibrous connective tissue begins to form within the vessel wall to reinforce the ballooned areas.
But I'm guessing that laying down thick scar tissue inside a tiny pipe that needs to be perfectly smooth and flexible is not a great long-term engineering solution.
It is a disastrous physiological solution. As the vessel wall heals, the innermost layer, the intima, proliferates and thickens rapidly to cover the damage. This dense, thick scar tissue significantly narrows the lumen, the actual open space inside the pipe where the blood flows.
And that narrowing is the stenosis.
Exactly. In severe cases, the vessel can become almost entirely occluded by its own scar tissue.
And a narrow pipe means the blood slows down.
It slows down, and the flow becomes turbulent rather than smooth. Yeah. Sluggish, turbulent blood flow moving over irregular scar tissue creates the absolute perfect environment for platelets to clump together and form a blood clot, a thrombus.
Oh, no.
And if a massive thrombus forms in a coronary artery that is already narrowed by scar tissue,
the blood flow to the heart muscle is instantly cut off. The muscle tissue suffocates and dies. A myocardial infarction.
yes, that is the timeline of the microscopic war, from the first inflammatory swelling to the final fatal plot.
Okay, so that is the hidden terror happening inside the chest. But what does this look like to a panicked parent rushing their child into the emergency room? Because the external symptoms mirror that internal war.
They do, yes.
Let's break down the clinical presentation. It also happens in 3 stages: the acute, the subacute, and the convalescent stages.
Let's start with the acute stage, which generally lasts for the first 1 to 2 weeks of the illness. The absolute undeniable hallmark of this stage is the fever. But it's critical to understand that this is not your standard run-of-the-mill viral fever.
But this isn't give them some acetaminophen and let them watch cartoons territory.
Not at all. It is an abrupt, high-grade fever, typically spiking to 39 or 40 degrees Celsius. That's 102 to 104 degrees Fahrenheit.
That's incredibly high for days on end.
And its defining clinical characteristic is that it is remittent, meaning it never truly comes down to a normal baseline, and it is entirely unresponsive to standard antipyretics like ibuprofen or acetaminophen. You give the medication and the fever just burns right through it.
Wow.
Furthermore, because it's an autoimmune vasculitis, it does not respond to antibiotics. If a doctor misdiagnoses it as a severe bacterial infection and prescribes amoxicillin, the fever will remain untouched. Untreated, this fever can rage relentlessly for 3 to 4 weeks.
104-degree fever that won't break for a month. That alone is terrifying. But eventually, usually around weeks 4 to 6, we enter the subacute stage. The fever finally drops. As a parent, you would think, oh, thank God, the worst is over. We survived.
And that is the cruelest deception of Kawasaki disease. The fever subsides, the child might even seem a bit brighter, but physiologically, this is actually when the danger is at its absolute peak.
Why? What is happening internally during week 4?
If we cross-reference this with the microscopic timeline we just discussed, the subacute stage is precisely when that internal elastic lamina is heavily fragmented. This is the exact window when the coronary aneurysms are rapidly expanding.
Ugh.
But the danger is compounded by what is happening in the blood itself. A routine, complete blood count during this phase will show a massive, terrifying spike in platelets.
Thrombocytosis. Platelets are the cells responsible for clotting blood. Right, like when you get a paper cut, they plug the hole.
Exactly. A normal platelet count might be 200,000 to 300,000 per microliter of blood. In the subacute stage of Kawasaki, platelet counts can skyrocket over 1,000,000 per microliter.
A million.
Yes. So you have a scenario where the blood vessels feeding the heart are heavily damaged, ballooning out, creating sluggish, turbulent blood pools, and simultaneously the blood flowing through them is hyper-primed to clot. It is a lethally synergistic combination.
And clinically on the outside of the body, what are the doctors seeing during this subacute phase?
You see a very distinct, almost bizarre symptom, membranous desquamation. This is the heavy, sheet-like peeling of the skin, specifically starting at the tips of the fingers and toes, often right around the nail beds.
Ouch.
Yeah, the severe inflammation in the tiny capillaries of the extremities causes the top layers of the skin to die and slough off.
That is such a specific, visceral detail. And finally, we hit the convalescent stage.
This can last up to 3 months from the initial fever. The outward clinical signs, the rash, the swollen lymph nodes, the peeling eventually resolve. The blood markers of inflammation slowly return to normal.
So they're out of the woods.
Not necessarily. The child is still at profound risk, depending entirely on the architectural state of their coronary arteries. Visually, in this late stage, you might notice deep, transverse grooves growing out on their fingernails and toenails. These are called bowlines.
Bowlines. What causes a dent in a fingernail?
It's essentially a physical, historical record of the severe systemic stress the body went through weeks earlier. During the height of the acute inflammatory phase, the body diverts all its energy to fighting the perceived threat. Processes like nail growth are completely halted at the nail matrix.
Oh, I see.
So when the disease subsides and growth resumes, it leaves a distinct horizontal groove that slowly grows out over the next few months.
Okay, so let's put ourselves in the shoes of an ER doctor.
Yeah.
A kid comes in with a raging, untouchable fever, maybe a rash, and some swollen glands.
Yeah.
If I'm looking at this critically, I have to ask, How does a physician know it's not just an aggressive case of measles, or a weird presentation of strep throat, or adenovirus?
Right.
Because you mentioned earlier, there is no single definitive blood test for Kawasaki disease, right?
Oh,
You
right.
can't just draw a vial, run it through a machine, and get a positive or negative.
And that is the ultimate diagnostic challenge of Kawasaki disease. It is entirely a clinical diagnosis. This means physicians have to rely on their observational skills to recognize a very specific, mandated pattern of physical symptoms.
So they use a checklist.
Exactly. Because the stakes are a potential pediatric heart attack, the American Heart Association has established exceptionally strict diagnostic criteria to help doctors separate the signal from the noise.
The AHA criteria. This is the checklist that saves lives. Let's break down exactly what they are looking for, because it's not just a random list. Each symptom tells a story of systemic vascular inflammation. What is the baseline requirement?
The absolute non-negotiable baseline is a fever lasting for 5 days or more. Without that prolonged fever, you generally cannot make a classic Kawasaki diagnosis. Once that 5-day threshold is met, the physician needs to observe at least 4 of the following 5 specific clinical signs.
Let's go through them. Sign number 1.
Extremity changes. We touched on the peeling later on, but initially in the acute phase, you see intense erythema, a deep angry redness and severe edema or swelling of the palms of the hands and the soles of the feet.
So they look puffy and red.
Very much so. The blood vessels in the extremities are leaking fluid into the tissues. The swelling can be so firm, tight, and painful that a toddler will absolutely refuse to bear weight or walk.
Okay, so swollen, rigid, red hands and feet. What's the next sign? Let's talk about the skin in general.
Sign number 2 is a polymorphous rash. Polymorphous means it can take many different forms. It might look like raised hives, urticaria, or a diffuse, flat, red, sunburn-like rash maculopapular, or even target-like lesions.
Is it usually all over?
It's often highly concentrated and much worse in the groin area. But here is the crucial negative differentiator. The rash is never vesicular.
Meaning no blisters.
Exactly. It does not form tiny, fluid-filled blisters or pustules like you would see in chickenpox or hand, foot, and mouth disease. Vesicles usually imply a virus actively replicating in the skin cells. In Kawasaki, the rash is a secondary reaction to the inflamed blood vessels running underneath the skin, not an infection of the skin itself.
That distinction makes perfect sense.
Okay.
Sign number 3. And visually, this is often the most striking to parents.
Oropharyngeal changes. The inflammation heavily targets the mucous membranes of the mouth. The lips become severely erythematous, bright red, they dry out, they crack deeply, and they often bleed. And then there is the classic strawberry tongue.
I want to pause on the strawberry tongue. What is the actual mechanism there? Why does a tongue look like fruit?
It's a fascinating localized breakdown of tissue. A healthy tongue is covered in a slightly whitish, textured coating made of tiny bumps called filiform papillae. In Kawasaki disease, the intense body-wide inflammation causes that entire protective top layer of the tongue to physically slow off.
Oh, wow.
Yeah. Underneath that layer are the fungiform papillae, which house the blood vessels. Because the child is in a hyperinflammatory state, those exposed blood vessels are engorged and dilated.
So it's raw.
Exactly. What you are left with is a raw, bright red, glistening tongue with prominent swollen bumps sticking up all over it. It mimics the textured surface of a bright red strawberry perfectly. You will also see diffuse redness all over the back of the throat, the pharynx.
Which, if you just looked at the throat quickly, could easily be confused for severe strep throat.
Absolutely.
But that's why you need the combination of signs. Which brings us to sign number 4, the eyes.
Bilateral conjunctivitis. The whites of both eyes become intensely injected, a glaring, deep red. But again, just like the rash, the differentiator is what is not there. The conjunctivitis in Kawasaki disease is non-exudative.
Non-exudative, so no pus.
No pus, no thick, crusty, yellow discharge sealing the child's eyes shut in the morning.
Right, which you'd normally see with pink eye.
Exactly. That thick exudae is typical of a bacterial infection, where bacteria are actively multiplying and dying on the surface of the eye. In Kawasaki, the eyes are red simply because the tiny blood vessels in the conjunctiva are massively inflamed. It is a dry, glaring, vascular redness.
Red eyes but no pus.
Ah.
That is a massive clinical clue. And finally, sign number 5.
Acute cervical lymphadenopathy, a swollen lymph node in the neck. But to meet the AHA criteria, it has to be specific. It is overwhelmingly unilateral, meaning it only occurs on one side of the neck, not both.
Okay, just one side.
Yes. It must be significantly enlarged, at least 1.5 centimeters in diameter. And similarly to the eyes, it is non-purulent. It is a solid inflamed node, not a node actively filled with bacterial pus that might require draining.
So to synthesize this for you, the listener, if a child has over 5 days of an unyielding fever, PLUS4 out of these 5 signs, swollen or peeling hands and feet, a widespread rash with no blisters, cracked bleeding lips with a strawberry tongue, dry red eyes, and a large swollen lymph node on one side of the neck, that specific undeniable combination is the alarm bell.
Yes. And if a pediatrician sees that constellation, or even if they suspect an atypical case where maybe only 3 signs are clearly present, but the overall clinical picture points strongly to Kawasaki, they have to move with absolute urgency. The diagnostic window is closing, and the structural integrity of the heart is on the line.
Which brings us to the critical phase of intervention, quantifying the damage and extinguishing the fire. Once that clinical diagnosis is made, it is a literal race against time to save the child's coronary plumbing. How do cardiologists actually look inside a beating toddler's heart to see if those aneurysms are forming?
The primary non-invasive diagnostic tool is the echocardiogram, a specialized ultrasound of the heart. It allows the pediatric cardiologist to visualize the muscular function, the valves, and crucially, to trace the path and size of the coronary arteries. But pediatrics introduces a major variable.
Which is?
You can't just measure a coronary artery, see that it is 4 millimeters wide, and definitively say, that's dangerously enlarged.
Right, because a 4-millimeter artery in a tiny 6-month-old infant is vastly different in proportion than a 4-millimeter artery in a tall 5-year-old child. Absolute measurements don't tell the whole story when the patients are constantly growing.
Exactly. Children vary wildly in height and weight. To solve this, pediatric cardiologists rely on a statistical tool called z-scores. Instead of using raw millimeters, a z-score indexes the absolute measured size of the coronary artery against the child's specific body surface area, or BSA.
Body surface area, how does that normalize the data?
By calculating the child's BSA based on their exact current height and weight, the z-score tells the cardiologist exactly how many standard deviations that specific artery is from the statistical norm for a perfectly healthy child of that exact same size. It mathematically levels the playing field, allowing for precise risk categorization.
So what are the specific cutoff scores they're looking for on that echo report?
The AHA classification based on z-scores is incredibly rigid. A z-score of less than 2 indicates no involvement. The arteries are considered normal. A score ranging from 2 to less than 2.5 is classified as mere dilation.
It's just slightly stretched.
Right, likely due to the edema of the early inflammatory phase, but they haven't ballooned into true aneurysms yet.
When do we cross the threshold into true structural failure?
A z-score from 2.5 up to less than 5 is formally classified as a small aneurysm. The wall is compromised. From 5 up to less than 10, provided the absolute dimension is still under 8 millimeters, is categorized as a medium aneurysm.
And what's the worst case scenario?
The most dangerous, terrifying category is a z-score of 10 or greater, or any absolute internal dimension of 8 millimeters or larger, regardless of the z-score. These are classified as large or giant aneurysms. These have the absolute highest risk of sluggish blood flow, massive thrombosis, and catastrophic rupture.
Okay, so the echo is running, the cardiologist is calculating the z-scores, and let's say they confirm the dilation, the diagnosis is locked in, the vascular fire is raging. What is the specific aggressive protocol to stop the inflammation before a giant aneurysm forms?
The absolute mainstay of treatment, the primary weapon deployed in every confirmed case, is intravenous immunoglobulin, universally known as IV.
What exactly is IV? How does it put out the fire?
IVG is a biological marvel. It is essentially a massive, highly concentrated pool of IgG antibodies, gathered and purified from the blood plasma of thousands, sometimes tens of thousands of healthy adult donors.
So you are taking the collective immune memory, the immune experience of thousands of people, and dripping it straight into this toddler's veins.
That is exactly what you are doing. And its mechanism in Kawasaki disease is fascinating. It doesn't act as a targeted vaccine. When infused at massive doses, it acts as a profound immunomodulator.
Oh, so.
Remember those destructive chemokines we talked about, the TNF and VEGF that act like molecular scissors cutting the vessel walls?
Yeah, the ones dissolving the rebar.
Right. The massive influx of cooled antibodies in IVG essentially blankets the child's overactive immune system. It binds to the FDC receptors on the child's hyperactive immune cells, flipping their off switch.
Oh, wow.
It directly neutralizes those rogue chemokines in the bloodstream, acting like a chemical sponge, rapidly shutting down the inflammatory cascade that is actively dissolving the coronary arteries.
And the dosing on this has to be incredibly precise to achieve that blanket effect, right?
It is a massive, carefully calculated dose. It is administered at exactly 2 grams per kilogram of the child's body weight. Because it is such a heavy protein load, it must be infused slowly and continuously over 10 to 12 hours.
And they have to do it quickly after diagnosis.
The timing is everything. It needs to be administered as soon as humanly possible, ideally well within the first 10 days of the fever's onset, to halt the inflammation before the irreversible aneurysms have a chance to form.
So IVG shuts down the immune assault. It stops the molecular scissors. But we still have a massive mechanical problem. You have millions of excess platelets swarming around in the blood, absolutely primed to form a deadly clot inside those freshly damaged irregular arteries. How do you handle the plumbing aspect while the IVG does its work?
That brings us to the second, equally crucial pillar of the management protocol: aspirin.
Wait, hold on. Aspirin. For a child with a fever, isn't that the exact thing pediatricians drill into parents' heads never to do?
It absolutely is.
I mean, every bottle of Tylenol has a warning about Ray's syndrome, that rare but fatal condition that causes massive swelling in the liver and brain if you give aspirin to a kid with a viral illness. Why are we blatantly breaking the golden rule of pediatrics here?
It's a brilliant question, and it perfectly highlights the unique extreme triage that Kawasaki disease demands. You're completely right. Giving aspirin to children with an undifferentiated viral fever is strictly contraindicated because of the terrifying risk of Ray's syndrome.
Right.
However, in the context of Kawasaki disease, the medical calculus changes entirely. The imminent, statistically high, and well-documented risk of a toddler dying from a massive myocardial infarction due to a clot forming in a coronary aneurysm far, far outweighs the exceptionally rare theoretical risk of Ray's syndrome.
So you just have to take the risk.
Yes. In this specific scenario, the protocol is heavily, unapologetically weighted towards saving the child's heart.
That puts the severity of the disease into stark perspective. The immediate threat of a heart attack completely overrides the standard safety warnings. So how do they administer the aspirin? Because it's not just a single dose. It's a strategic dual-phase approach.
Yes, the pharmacology shifts as the disease progresses. During the acute phase, while the fever is still raging, we need the systemic anti-inflammatory properties of aspirin. It is given at an incredibly high dose, 80 to 100 milligrams per kilogram per day.
That's a lot.
It is. Now, I should note that some newer regional guidelines suggest a slightly more moderate but still high dose of 30 to 50 milligrams per kilogram per day, but the principle remains the same. This massive dose is divided up and given every 6 hours, and it is continued aggressively until the patient has been completely febrile, meaning zero fever, for at least 48 continuous hours.
So you blast the inflammation from two sides, the IVG blanket and the high-dose aspirin. Once that fever finally breaks and holds for 2 days, what is the transition?
Once the acute inflammation is subdued, we transition to the maintenance phase. The aspirin is drastically dropped down to a much lower, strictly antiplatelet dose. This is usually just 3 to 5 milligrams per kilogram per day, given as a single daily dose.
What does that low dose do differently?
At 3 to 5 milligrams, the aspirin is no longer fighting inflammation. Instead, it selectively inhibits an enzyme in the platelets, essentially making them slippery.
Okay.
It prevents them from aggregating, clumping together, and forming a catastrophic clot inside those vulnerable healing blood vessels. This low protective dose is rigidly maintained for 6 to 8 weeks.
And what happens at the 8-week mark?
At 8 weeks, the child undergoes another comprehensive echocardiogram. If the echo shows that the coronary arteries are completely normal, that no aneurysms formed, or that any mild dilation has completely resolved, the aspirin can finally be discontinued. The child is clinically cleared.
But what if the aneurysms persist? What if the damage was done before the IVD could stop it?
If aneurysms are present, particularly the medium or giant aneurysms with Z-scores over 5 or 10, the child remains in extreme danger of a clot. In those cases, the child will need to remain on antiplatelet therapy indefinitely.
Wow.
Forever.
Sometimes, yes. Often, the low-dose aspirin isn't enough, and cardiologists must add a second antiplatelet drug like clopidogrel, or even escalate to full systemic anticoagulants like warfarin or low molecular weight heparin, requiring lifelong monitoring and severely restricting the child's physical activities to prevent bleeding.
It is a phenomenal, harrowing medical intervention. You literally extinguish a fire burning inside the vascular plumbing of a toddler. But as we transition into the second half of our deep dives, we have to completely change our perspective.
Yes, the pathology shifts entirely.
If Kawasaki disease is an external attack by an erratic immune system on the heart's plumbing, the conditions we are about to explore, the pediatric cardiomyopathies, are internal betrayals.
Right.
They are intrinsic structural flaws built into the heart muscle itself. We are moving from the supply lines to the literal concrete walls of the pumping station. Let's start with a heart that just grows too thick. Hypertrophic cardiomyopathy, or HCM. What is fundamentally broken here?
Hypertrophic cardiomyopathy is, at its root, a genetic disease. It is primarily an autosomal dominant disorder. This means if one parent carries the mutated gene, a child has a 50% chance of inheriting the condition.
Where do these mutations happen?
The mutations occur specifically in the genes that encode the various protein components of the cardiac sarcomere.
The sarcomere. Let's zoom in on that. What is a sarcomere, and why does a mutation there cause the heart to enlarge?
The sarcomere is the absolute basic microscopic contractile unit of all muscle tissue. Inside every cardiac muscle cell, there are these overlapping filaments of proteins, primarily myosin and actin. When the heart receives an electrical signal, these filaments grab onto each other and slide past one another, physically shortening the cell.
Okay, so that shortening is what creates a contraction.
Yes. Billions of these tiny shortenings happening simultaneously is what creates the forceful squeeze of a heartbeat.
So the sarcomere is the tiny engine inside the muscle fiber.
Exactly. But in HCM, there is a genetic typo in the blueprint for building those specific myosin or binding proteins. Because the proteins are flawed, the sarcomeres don't assemble perfectly parallel to each other. They form chaotic, disorganized swirls, a phenomenon pathologists call myocardial disarray.
Oh, that doesn't sound good.
It isn't. The heart muscle senses this inefficiency. It realizes it isn't contracting with optimal force, so it attempts to compensate the only way it knows how, by adding more muscle mass. It hypertrophies. The myocardial muscle cells grow abnormally large, and the walls of the heart thicken dramatically.
And it doesn't just thicken evenly like a bodybuilder's bicep, does it? The growth is skewed.
That asymmetry is a defining hallmark of the disease. The thickening is particularly extreme in the intraventricular septum. This is the central muscular wall that divides the left and right ventricles of the heart. In HCM, the septum balloons outward, often becoming significantly disproportionately thicker than the posterior outer wall of the left ventricle.
So you have this massive bulging wall growing right in the center of the heart chamber. Now, there is a very critical distinction made in cardiology between two types of this disease, HOCM and non-obstructive HCM. What's the difference, and why does it matter so much?
The difference is entirely mechanical, and it dictates the severity of the symptoms. The primary job of the left ventricle is to forcefully pump oxygenated blood out through the aortic valve and into the aorta to supply the entire body. The specific internal pathway the blood must take to reach that aortic valve is called the left ventricular outflow tract, or LVOT. If that genetically overgrown, thickened intraventricular septum bulges so far into the chamber that it physically narrows or blocks that outflow tract, preventing blood from easily exiting the heart, that is hypertrophic obstructive cardiomyopathy, HOCM.
Okay, when I was trying to conceptualize this, I pictured HOCM like a massive bouncer working the door at a crowded nightclub.
I like this analogy.
Yeah, so the bouncer's assigned station is right next to the exit door. But this particular bouncer has a genetic mutation that made him spend way too much time at the gym. He has gotten so massively, absurdly huge that his mere presence is accidentally blocking the exit.
Right.
He isn't actively trying to trap the patrons inside, but his sheer disproportionate bulk is causing a massive traffic jam. The blood simply cannot squeeze past him to get out of the club.
That is a phenomenal, highly accurate visual metaphor. The muscle is just blindly following its mutated genetic instructions to grow, but its specific anatomical location turns that growth into a deadly obstruction.
And if it's non-obstructive?
If, however, the septal thickening occurs, but it does not happen to impinge upon or block that outflow tract, it is classified as simply non-obstructive HCM. The muscle is still abnormally thick, it is still stiff, and the chaotic cellular architecture still poses electrical risks, but the exit door remains open.
How does a cardiologist spot this bouncer blocking the door without opening the chest? What are the clinical signs they hear or feel in the exam room?
Because the blood is being forcefully squeezed through a severely narrowed exit in obstructive HOCM, it creates high-velocity turbulence. Clinically, when a doctor listens with a stethoscope, this turbulence presents as a loud, harsh ejection systolic murmur, a very distinct whooshing sound heard precisely when the heart squeezes.
What else do they look for?
Additionally, because the left ventricle is working so incredibly hard to push blood past that obstruction, it creates a powerful thrust that the doctor can actually feel on the patient's chest wall, known as a prominent apical impulse.
And there's a specific abnormal extra heart sound they listen for, right? An S4.
Yes, the presence of a fourth heart sound, or an S4 gallop. A normal, healthy heart produces two main sounds, the classic lub-dub, representing the closing of different valves. An S4 is an extra low-pitched sound that occurs just a fraction of a second before the lub.
What causes that extra sound?
It happens because the receiving chambers, the atria, are trying to forcefully push the last bit of blood into a left ventricle that is so enormously thick and stiff from the hypertrophy that it refuses to relax and expand. The S4 sound is the literal acoustic vibration of the blood forcefully striking that rigid, unyielding ventricular wall.
But the definitive diagnosis relies on seeing the mechanics in motion on an echocardiogram.
Absolutely. The echo clearly reveals the asymmetric septal hypertrophy, confirming the diagnosis. But in obstructive cases, the echo also captures a fascinating and dangerous dynamic phenomenon called systolic anterior motion of the mitral valve.
Systolic anterior motion. What does that mean in plain English? What is the valve doing?
It's a matter of fluid dynamics. Because the blood is rushing at an abnormally high velocity through that narrowed outflow tract, past the bulging septum, it creates a localized drop in pressure, a vacuum effect known in physics as the Venturi effect.
Oh, like when wind rushes between two tall buildings.
Exactly. This suction is so powerful that it actually grabs the anterior leaflet of the mitral valve and pulls it forward into the outflow tract during systole, the squeeze.
So the valve leaflet gets sucked into the doorway too.
Yes. It's a mechanical double whammy. The bulky septum is already blocking the door, and the suction pulls the valve leaflet in to block it even further. And because the mitral valve is being pulled out of its normal closed position, it can't seal properly, causing blood to leak backward into the atrium mitral regurgitation. The heart is working twice as hard to pump half as much blood.
And the consequences of this mechanical and electrical disarray can be absolute nightmare fuel. This condition carries a very specific, sobering clinical distinction.
It is deeply sobering. Hypertrophic cardiomyopathy is the most common, identifiable, non-traumatic cause of sudden cardiac death in young, otherwise healthy athletes on the playing field.
It's the tragedy you see on the local news once a year. A healthy, elite high school basketball player or a college soccer star just suddenly collapses mid-sprint and they don't get back up.
It is devastating, and the physiology behind it explains why it happens during sports. The intense physical exertion of competitive athletics demands a massive, immediate increase in cardiac output. The heart needs to pump vastly more blood to the muscles, but the obstructed, thickened HOCM heart physically cannot increase its output because the bouncer is blocking the door.
Right.
Alternatively, the massive surge of adrenaline combined with that chaotic, swirling cellular architecture of the thickened muscle, the myocardial disarray creates a perfect storm for a short circuit. It triggers a fatal electrical arrhythmia, typically ventricular fibrillation, where the heart stops pumping and just uselessly quivers.
So how do cardiologists figure out which kids with HCM are at risk for this sudden death and which ones will live relatively normal lives? You can't ground every child with a murmur.
Right, and risk stratification is the most critical part of managing HCM. Overall, the risk of sudden cardiac death in an HCM patient is roughly 1% per year. But cardiologists look for very strict, specific criteria that elevate a patient into the high-risk category.
Let's run through those red flags. What makes a patient high risk?
First, the age of diagnosis. Being diagnosed in childhood or adolescence is a significantly higher risk factor than developing symptoms as an adult. Second, they look at the sheer absolute mass of the muscle on the echo. A septal wall thickness of greater than 30 millimeters is a major independent red flag for sudden death.
Okay, what else?
Third, they look at the electrical system using a 24-hour Holter monitor, searching for episodes of non-sustained ventricular tachycardia.
Non-sustained ventricular tachycardia. That means the heart's electrical system is briefly short-circuiting and beating dangerously fast, but it resolves itself before the patient passes out.
Exactly. It's a tremor before an earthquake. It proves the electrical pathways are unstable. Another crucial test is a treadmill exercise stress test. Normally, your blood pressure rises steadily as you exercise to meet the body's demand.
Sure.
In some high-risk HCM patients, their blood pressure fails to rise or actually drops during exertion, proving that the obstruction is so severe the heart cannot increase cardiac output when challenged.
Wow, dropping blood pressure during a run. That's alarming.
Yes. Finally, a strong family history of premature sudden cardiac death associated with HCM, the presence of a severe resting left ventricular outflow tract obstruction, and obviously a prior personal history of a cardiac arrest or unexplained fainting spells, syncope are all major indicators that the patient is in imminent danger.
If a teenager hits those high-risk criteria, what is the medical management? Because you can't just prescribe a pill to tell a genetic mutation to stop building muscle.
For patients stratified as high risk for sudden death, the primary life-saving intervention is the surgical implantation of an AICD, an automatic implantable cardioverter defibrillator.
What does that do?
This device is essentially a miniaturized internal emergency room wired directly into the heart muscle. It constantly monitors the heart rhythm. If it detects that the heart has slipped into a fatal arrhythmia like ventricular fibrillation, it instantly, automatically delivers a powerful electrical shock to reset the heart's electrical grid and save the patient's life.
It catches them before they hit the ground.
Yeah.
And for the patients who perhaps aren't in that immediate high-risk category for sudden death, but are still suffering from the thick muscle, the stiffness, and the shortness of breath, how do you treat the symptoms?
The pharmacological management of HCM requires a counterintuitive approach. The goal is not to make the heart squeeze harder.
Right, because making it squeeze harder just forces the bouncer into the doorway more forcefully, worsening the obstruction and the suction effect.
Exactly. Instead, the frontline medications are beta blockers. Beta blockers actively slow the heart rate down and blunt the heart's response to adrenaline. By slowing the heart rate, you extend diastole, the resting phase of the heartbeat,
Giving it more time to fill.
Yes, this gives that incredibly thick, stiff, non-compliant ventricle more time to relax, slowly open up, and adequately fill with blood before the next contraction. Cardiologists might also use calcium channel blockers or specific antiarrhythmic drugs like amiodarone to keep the electrical system calm.
But what if the obstruction, the physical bulk of the septum, is just too massive? What if medications can't overcome the physical traffic jam? Can surgeons go in and physically remodel the heart?
Yes, for patients with severe, highly symptomatic obstructive HCM that fails to respond to medication, there are physical interventions. The gold standard is a surgical myectomy. This is open heart surgery, where a surgeon goes in and physically scalps away or resects a portion of the overgrown thickened septum, physically widening the outflow tract.
They literally carve out a wider exit door.
Yes. A less invasive alternative is an alcohol septal ablation. In this catheter-based procedure, a cardiologist navigates a wire into the specific tiny coronary artery that feeds the overgrown portion of the septum. They then inject a small amount of absolute pure alcohol directly into that artery.
Wait, they inject alcohol into the heart?
Yes. The alcohol is highly toxic to the tissue. It causes a localized, highly controlled, intentional heart attack. The overgrown muscle tissue dies, and over the next few months, it shrinks and scars down, widening the outflow tract without requiring open heart surgery.
That's incredible.
It is. And it is vital to note that all patients diagnosed with HCM, regardless of their current symptom severity or treatment, are strongly, universally advised by cardiologists against participating in intense, competitive, stop-and-start sports. The physiological demands are simply too unpredictable for that specific cardiac architecture.
It is a heavy diagnosis to hand to a teenager, but the mechanical ingenuity of the management strategies, from the internal defibrillators to the controlled ablations, is incredible. But now, we must pivot once again. We've explored the heart with the blocked supply lines in Kawasaki. We've looked at the genetically overgrown thick heart of HCM. Now we move to the third condition, restrictive cardiomyopathy, or RCM. We are moving from a heart that is too thick to a heart that is too stiff.
This represents a completely different pathophysiological mechanism. In HCM, the primary problem was systolic and obstructive. The muscle was too bulky and got in its own way while squeezing. In restrictive cardiomyopathy, the defining hallmark is severe diastolic dysfunction.
Diastolic dysfunction, meaning the heart has no problem squeezing the blood out, but it fundamentally cannot relax and expand to let new blood in.
Precisely. In RCM, the overall interior volume of the heart chambers might be entirely normal or perhaps only slightly decreased. The muscular walls aren't necessarily massively hypertrophied or visibly thick on an echo like we saw in HCM, but those walls have become incredibly pathologically stiff.
What makes them so stiff?
The healthy, elastic muscle tissue has been heavily infiltrated by abnormal systemic substances like amyloid proteins or iron deposits, or it has been replaced by dense, unyielding fibrotic scar tissue. Imagine taking a supple, highly elastic rubber balloon and replacing it with a balloon stitched together out of thick, stiff canvas.
Oh, that's a great visual.
Yeah, you can still forcefully squeeze the air out of the canvas balloon with your hands, but when you let go, it doesn't naturally snap back and expand to draw new air in.
The heart can effectively pump out whatever volume is inside it, but it cannot stretch to accept the next critical load of venous blood returning from the body. It becomes a rigid, unyielding box.
Right, and while restrictive cardiomyopathy is generally the rarest of the three main types of cardiomyopathy globally, the clinical data highlights a very specific primary form of RCM that presents an absolute medical and geographic enigma. It's a condition called endomyocardial fibrosis, or EMF.
This specific section of the data was genuinely mind-blowing to review. Let's look at the epidemiology of EMF because it completely defies the typical randomized patterns of genetic or systemic diseases. Where is this happening?
The geographic distribution is striking and highly localized. Over 90% of all recorded endomyocardial fibrosis cases occur within a very specific, narrow geographic band within 15 degrees north and south of the equator.
15 degrees. That's incredibly specific.
It is. It is predominantly found in the tropical and subtropical regions of Africa, with massive concentrations in countries like Nigeria and Uganda. It is also seen, to a lesser extent, in parts of tropical South America and India.
And within those specific equatorial zones, it's not just a rare medical oddity, is it? It's a crisis.
Far from it. The burden of disease is staggering. In Nigeria, for example, EMF is the fourth most common cause of all cardiac disease in adults. And even more tragically, it accounts for up to 22% of all pediatric heart failure cases in Nigerian children.
22%.
Yes. It is a massive, localized public health catastrophe in these specific equatorial zones, yet it is virtually unheard of in temperate climates like North America or Europe, unless the patient has recently emigrated from an endemic region.
So naturally, the screaming question is, why? What specific insidious factor exists exclusively within 15 degrees of the equator that is physically stiffening and scarring the hearts of young children?
This is one of the great enduring unsolved mysteries of tropical medicine. Several fascinating hypotheses have been proposed over the decades, but none have been definitively, universally proven to be the sole causative agent.
What are the main suspects?
Many researchers suspect it is an aberrant, delayed immune hypersensitivity reaction to parasitic infections that are heavily endemic to the tropics. They look at organisms like loa loa, the African eyeworm, or widespread parasites like toxoplasma.
Okay, parasites make sense for the tropics.
Right. Others suggest it might be a hypersensitivity to recurrent streptococcal bacterial infections, a mechanism similar to how strep throat leads to rheumatic heart disease, but manifesting as endocardial scarring instead of valve destruction.
But then there are the dietary and environmental theories, which I found to be the most fascinating aspect of this entire puzzle.
Yes, the focus on local agriculture is compelling. One early prominent theory postulated that the excessive daily consumption of certain varieties of plantains, which naturally contain a very high serotonin content, might be driving the disease.
Right, serotonin in plantains.
Yes. High systemic circulating serotonin levels are known to cause fibrotic damage to right-sided heart valves in other medical contexts, like carcinoid syndrome.
But the theory that really caught my attention was the soil hypothesis, the cerium.
That is currently the most intriguing and actively investigated geochemical hypothesis. Researchers analyzing the soil in the specific endemic regions of Uganda and Nigeria found that a rare earth element called cerium is present in unusually high concentrations.
Okay.
The cerium is absorbed from the soil and heavily taken up by cassava plants, which are a primary daily carbohydrate staple food crop for millions of people in these areas.
So the children are ingesting this rare earth element every single day.
Yes. And the theory suggests that cerium acts as a toxic substitute in the body. In individuals with diets already critically low in magnesium hypomagnesemia, the cerium can substitute for magnesium in the cellular pathways of the heart muscle.
And what does that substitution do?
This substitution is highly toxic and actively promotes fibrogenesis, the creation of scar tissue. In laboratory settings, feeding animals a highly specific diet combining elevated cerium levels with low magnesium has actually successfully reproduced EMF-like fibrotic lesions in their hearts.
That is wild. The possibility that the very earth they grow their sustenance in, the specific atomic makeup of the local dirt, is toxic to the structural integrity of a child's heart muscle. regardless of whether the ultimate trigger is a parasite, a plantain, or cerium in the soil. How does this disease actually physically progress inside the heart? Because like Kawasaki, it unfolds in distinct phases.
Yes, the pathology of EMS is a slow, relentless progression. The first phase, which usually occurs in the first 5 weeks of the active illness, is heavily marked by an eosinophilic infiltration of the myocardium, accompanied by tissue necrosis.
Eosinophils, we mentioned them briefly in Kawasaki. What are they?
Eosinophils are a highly specialized type of white blood cell that the immune system typically deploys to fight off large multicellular parasitic infections or heavily engages during severe allergic reactions.
So they flood the heart.
Yes, in this initial phase of EMF, massive numbers of eosinophils flood the inner layers of the heart muscle. They release toxic granules that cause widespread necrosis death of the healthy cardiac tissue.
And phase 2, how does the heart respond to that initial tissue death?
Around 10 months into the disease process, you transition to the second phase. As the acute eosinophilic inflammation slowly starts to burn out and recede, the body attempts to cover the raw necrotic lesions inside the heart chambers. It does this through thrombus formation.
Blood clots again.
Right. Blood clots begin to form and adhere directly over these damaged areas on the inner walls of the ventricle.
And the final phase, the phase that actually creates that stiff, restrictive physiology.
Phase 3 occurs years later, and it represents the irreversible end stage of the disease. This is the fibrotic phase. The endocardium, the smooth, delicate innermost lining of the heart, and the immediate underlying muscle are progressively, relentlessly replaced by dense, thick, collagenous fibrotic tissue.
It's literally like pouring a layer of rigid concrete over the inner walls of the pumping chambers.
That is exactly the mechanical result. This patchy, dense fibrosis completely destroys the heart's compliance. It leads to that stiff, unyielding, restrictive physiology we discussed.
And it spreads, right?
It does. Furthermore, this fibrosis often begins at the apex, the very bottom tip of the ventricles, and slowly creeps upward. As the scar tissue thickens and contracts, it can literally engulf the papillary muscles and tether the leaflets of the tricuspid and mitral valves, permanently pulling them open and causing severe, unremitting valvular regurgitation.
To diagnose the severity of this concrete, doctors use a specific staging system based on the echocardiogram, right?
They do. The staging system utilizes 6 major criteria and 7 minor criteria observed on the echo, things like the thickness of the fibrotic patches, the degree of valve tethering, and the size of the atria. They assign a numerical score. A score of less than 8 indicates mild EMF. A score of 8 to 15 classifies it as moderate disease, and a score greater than 15 signifies severe advanced disease. So how does a child with severe late-stage EMF present clinically? Because when the heart turns to stiff concrete, the physical signs on the outside of the body are incredibly distinct and, frankly, devastating to visualize.
Because the right ventricle is so incredibly stiff and unyielding, the blood returning from the body simply cannot enter the heart efficiently. It hits a wall. So the blood pressure physically backs up into the venous system, engorging the organs and leaking fluid into the surrounding tissues.
And what does that look like?
The physical presentation of this specific backup in EMF is visually shocking. You see what is tragically termed in the literature as an egg on stick appearance.
What specifically causes that disproportionate look? Why an egg on a stick?
The child develops massive, tense ascites. Ascites is a huge accumulation of free fluid directly distending the abdominal cavity. However, unlike typical generalized heart failure, where you would normally see significant equal fluid swelling in the dependent areas like the feet and legs, pedal edema, the ascites in EMF drastically, almost exclusively outstrips the limb swelling.
Oh, I see. The child's abdomen becomes grotesquely distended, round and tight like an egg, but their arms and legs remain severely thin and emaciated due to cardiac cachexia, hence egg on a stick.
Why does all the fluid pool in the belly and not the legs?
It is thought to be exacerbated by a secondary complication called a protein-losing enteropathy. The high venous pressure backs up into the intestines, causing the gut to literally leak essential proteins like albumin into the digestive tract where they are lost.
And you need albumin to keep fluid in the vessels, right?
Exactly. Without sufficient albumin in the blood to hold fluid inside the blood vessels via oncotic pressure, massive amounts of fluid aggressively shift out of the vessels and pool directly into the abdominal cavity.
You also see dramatic, visible changes in the veins in the child's neck, right?
Yes, the jugular venous pressure is massively elevated. Because the stiff, fibrotic right ventricle has tethered and pulled the tricuspid valve permanently open, there is no seal between the right ventricle and the right atrium.
So the blood just flows backwards.
Right. Consequently, every single time the right ventricle squeezes, a massive volume of blood shoots backward through that incompetent valve, up through the atrium, and straight up into the major veins of the neck. This creates visibly pulsing, bounding, giant V waves traveling up the jugular vein with every heartbeat. You can diagnose the severe tricuspid regurgitation just by looking at the child's neck from across the room.
And then there's the chest x-ray. The visual description of the x-ray in these patients is absolutely unforgettable.
It is pathognomonic. It is diagnostic in itself. Because the right ventricle is encased in stiff fibrosis and cannot expand, the right atrium, the thin-walled receiving chamber resting above it, is forced to stretch to an absolutely enormous size as it attempts to hold all that backed-up venous blood.
Wow.
On a standard chest x-ray, this massive, disproportionate right atrial enlargement creates a highly specific cardiac silhouette that literally mimics the shape of the continent of Africa. In tropical medicine, it is formally termed the Heart of Africa sign.
A physical map of the disease's epidemiology literally stamped right onto the child's chest x-ray. It's incredibly poetic, but horribly grim. What is the ultimate prognosis for these kids?
The prognosis is exceptionally poor. Medical management is largely entirely palliative, meaning it focuses on symptom relief, not a cure. Doctors utilize heavy doses of diuretics to try to pull that massive fluid volume off the abdomen and lungs, and they use ACE inhibitors, ARBs, and beta blockers to try to manage the progressive heart failure. But these drugs cannot dissolve the fibrotic concrete.
Can surgeons go in and try to fix it, like peeling the concrete off?
In severe intractable cases, specialized surgeons can attempt a highly complex procedure called an endocardial decortication. This means putting the child on bypass, opening the heart, and literally attempting to peel and scrape away that thick layer of fibrous scar tissue from the inner walls of the ventricles, hoping to allow the underlying muscle to relax and expand again.
That sounds incredibly risky.
It is. They often have to completely replace the tethered tricuspid and mitral valves during the same surgery. But the operative mortality rate is staggeringly high, historically around 15 to 20%. Ultimately, the long-term survival rate for EMF is grim. One specific study highlighted in the clinical data tracked a cohort of medically managed EMF patients, and a devastating 95% of them had died within just 2 years of their initial diagnosis, usually succumbing to progressive, intractable heart failure or fatal electrical arrhythmias originating from the scarred tissue.
It is a devastating, geographically isolated tragedy.
Which brings us to our final segment, the final condition in our exploration of pediatric cardiomyopathies. We've seen a heart that's too genetically thick and obstructive in HCM. We've seen a heart that's encased in stiff fibrotic concrete in RCM. Now we look at the exact opposite mechanical problem. What if the heart isn't thick and it isn't stiff, but instead becomes stretched out, dilated, and essentially floppy? This is dilated cardiomyopathy, or DCM. Historically, it is also sometimes referred to as congestive cardiomyopathy. It is the most common form of cardiomyopathy in children. The core pathophysiology here is fundamentally different.
How so?
In DCM, the left ventricle, the main pumping chamber, is massively dilated, meaning it is physically stretched and enlarged, and its systolic function, its sheer physical ability to contract and squeeze, is significantly dangerously decreased.
Okay, so if RCM was a stiff Kansas balloon, dilated cardiomyopathy is like a cheap rubber balloon that you've blown up and deflated 100 times over. You know how the rubber loses all its snap?
Yeah.
It just becomes thin, saggy, and floppy. It holds air, but it has no structural tension left.
I like the balloon analogy, but to really understand the physics of the failure, we need to think about the Frank-Starling mechanism.
The Frank-Starling mechanism. Walk me through that.
Imagine a thick, robust rubber band. If you stretch that rubber band just a little bit and let go, it snaps back with a certain predictable amount of force. If you pull it back further, stretching it more, it stores more potential energy, and it snaps back even harder.
Right. Makes sense.
The healthy heart muscle operates on this exact same principle. When a larger volume of blood fills the chamber during rest, the cardiac muscle fibers are stretched further, and they respond by contracting more forcefully to ensure all that extra blood is pumped out. But what happens if you take that rubber band and you stretch it as absolutely hard as you can, over and over, thousands upon thousands of times?
The structural integrity degrades. The rubber develops micro tears. It completely loses its elasticity. It can't snap back anymore. It just sags.
That is exactly what happens to the left ventricle in dilated cardiomyopathy. It becomes a sagging, degraded rubber band. The chamber physically dilates to accommodate blood, but the muscle walls have become thin, weak, and overstretched. The myocytes, the muscle cells, are damaged, so they completely lose that crucial, forceful snapback.
So how do you measure that loss of snapback?
The key clinical metric cardiologists use to measure this failure is the ejection fraction.
The ejection fraction.
Yeah.
That's a percentage of blood the heart successfully pumps out with every single beat, right?
Yes. A normal, healthy left ventricle doesn't empty completely, but it pumps out between 50 and 75% of the blood it holds with every contraction. In dilated cardiomyopathy, because the muscle is so floppy and weak, the ejection fraction plummets below 50%, and in severe cases, it can drop into the teens.
Into the teens. Wow.
Yeah, the heart is full of blood, but it simply cannot muster the strength to push it forward into the body.
Why does the muscle lose its squeeze in the first place? What triggers the rubber band to degrade?
The degradation is a vicious cycle, a cascade of physiological failure. It begins with an initial injury to the myocardial cells, which leads to localized cell death. This initial loss of healthy tissue results in an inadequate overall force of contraction.
Okay, so the pump gets weak.
Right. And the body's systemic sensors immediately detect that cardiac output has fallen, that the organs aren't receiving enough pressurized blood flow. The body panics, and it triggers a series of powerful, ancient compensatory mechanisms.
It tries to help the failing heart.
It tries to help, but its methods are entirely maladaptive and ultimately fatal. The kidneys activate the renin-angiotensin-aldosterone system, or RAAS, and the pituitary gland releases massive amounts of antidiuretic hormone, ADH.
What do those hormones do?
These hormones command the body to aggressively retain salt and water, vastly increasing the total blood volume. Simultaneously, they command the peripheral blood vessels to tightly constrict, attempting to artificially force the blood pressure back up.
But wait, the heart is already weak and floppy. So the body's solution is to dump a massive amount of extra fluid into a failing pump and then force that failing pump to push that extra fluid through pipes that have been tightly squeezed shut. That sounds like a recipe for a total blowout.
It is the exact definition of a vicious cycle. The increased volume stretches the already weakened heart, further dilating it more, and the constricted blood vessels drastically increase the afterload, the physical resistance the failing heart must push against.
That's terrible.
It is. These well-intentioned compensatory mechanisms vastly increase the workload on the damaged muscle, rapidly accelerating cell death and driving the exhausted heart straight into profound, irreversible congestive heart failure.
What causes that critical initial injury to the myocardial cells in the first place? Why does a child's heart muscle suddenly start dying?
The etiology of DCM spans a massive, incredibly diverse spectrum. In pediatrics, one of the leading culprits is viral myocarditis, a direct viral infection of the heart muscle tissue itself. Viruses like Kawasaki virus or an virus can infect the myocytes, causing inflammation and cell death that precedes roughly 50% of all pediatric DCM cases.
So a common virus just attacks the heart directly?
Yes, the child gets a viral illness, and a few weeks later, their heart begins to dilate and fail.
But it's not just viruses. The clinical data also pointed heavily to toxins.
Yes. In adults, chronic alcohol abuse or cocaine toxicity are major drivers of toxic DCM. But in pediatrics, the most prominent and tragic toxic cause is iatrogenic, meaning it is caused by medical treatment, specifically the prolonged use of doxorubicin.
Doxorubicin is a chemotherapy drug, right? Used for childhood leukemia and solid tumors.
Yes. It is an incredibly powerful, life-saving anthracycline chemotherapy agent. However, a known dose-dependent side effect is that it generates massive amounts of free radicals and oxidative stress that directly attack the mitochondria of the cardiac myocytes.
That's a cruel trade-off.
It is a cruel medical irony. It cures the child of cancer, but it physically breaks the cellular machinery of the heart muscle, leading to dilated cardiomyopathy years later.
What about genetics or diet?
Genetics play a substantial role. About 25% of DCM cases have a clear familial inheritance pattern. It is also heavily associated with severe neuromuscular disorders, most notably Duchenne muscular dystrophy, where the absence of the dystrophin protein causes both the skeletal muscles and the heart muscle to progressively weaken.
And diet.
There are also rare but important nutritional causes, such as severe deficiencies in carnitine or selenium, which are essential micronutrients the heart muscle requires to produce cellular energy.
How does dilated cardiomyopathy present clinically in a young child? Because unlike Kawasaki disease, which kicks the door down with a sudden 104-degree fever and peeling skin, DCM seems like it would sneak up on a family.
The onset is highly insidious. The heart is failing slowly. Parents might initially just notice vague, nonspecific symptoms, a chronic dry cough that won't go away, poor feeding in an infant where they sweat profusely and get exhausted just from trying to nurse.
Just general fatigue.
Exactly. general irritability, or easy fatigability. An older child simply can't keep up with their friends on the playground and constantly needs to sit down.
The data noted a very surprising specific symptom for infants that I think is crucial to highlight: wheezing.
Yes. When an infant is brought to a pediatrician with a prominent wheeze, the immediate statistical assumption is often a respiratory issue, infant asthma, or a viral bronchiolitis like RSV. But a wheeze can actually be a primary clinical sign of profound congestive heart failure.
How does a failing heart cause a lung wheeze?
Because the floppy left ventricle cannot effectively pump blood forward into the body, the blood pressure physically backs up backward into the pulmonary veins and into the lungs. This high venous pressure forces fluid to leak out of the pulmonary capillaries and directly into the tiny airways, the alveoli.
So the airways fill with fluid.
Yes, the airways become boggy and narrowed by fluid. As the infant struggles to breathe air through these narrowed, fluid-filled passages, it creates an audible wheeze. It is a critical differential diagnosis. Pediatricians must always keep a failing heart in the back of their minds when treating a wheezing infant.
When a child is finally diagnosed with dilated cardiomyopathy, what does the future look like? The data mentions a very stark, very simple statistical rule.
Yes, the 13 prognosis rule of DCM. Statistically speaking, if you look at a broad population of pediatric patients diagnosed with DCM, the outcomes divide almost perfectly into thirds.
Okay, what's the first third?
Roughly 1/3 of these patients will tragically succumb to the disease, dying from progressive, intractable heart failure or sudden fatal arrhythmias. Another 1/3 will survive the initial acute failure, but they will land in a state of chronic, lifelong heart failure, requiring intense daily pharmacological management, frequent hospitalizations, and eventually the need for a total heart transplant.
And the final third?
The final 1/3 will actually improve. Their heart muscle, aided by medical therapy, manages to heal, remodel, and recover significant, sometimes entirely normal, systolic function.
A literal life or death roll of the dice. For those in the middle third, the kids surviving but living with a heart that is just too exhausted to pump effectively, how do you pharmacologically treat a sagging rubber band?
Because the heart is a failing, overwhelmed pump fighting against the body's own maladaptive compensatory mechanisms, the medical strategy is twofold. You must aggressively decrease the workload on the heart and simultaneously increase the mechanical efficiency of the squeeze.
How do you decrease the workload? How do you undo the damage of those hormones constricting all the blood vessels?
The absolute cornerstone of therapy is the use of ACE inhibitors like enalapril or captopril. These drugs directly block the renin-angiotensin-aldosterone system. By doing so, they cause the peripheral blood vessels throughout the entire body to dilate and open up.
Making it easier to pump.
Exactly. This massively reduces the afterload, the physical resistance, the blood pressure that the weak, floppy heart has to push against. It's like opening all the locked doors in a hallway so you don't have to push as hard to get through.
What about the heart rate?
We utilize beta blockers like carvedilol. Now, initially this seems highly counterintuitive. Why would you want to slow down a heart that is already failing to pump enough blood?
Right, if the pump is weak, you'd think you wanted to pump faster to make up for it.
But pumping faster requires more oxygen, which the failing heart doesn't have. More importantly, beta blockers shield and protect the exhausted cardiac muscle from the highly toxic, overstimulating effects of chronic adrenaline exposure.
Oh, because the body is pumping out adrenaline to try and help.
Yes. Remember, the failing body is constantly pumping out adrenaline to try to force the heart to work harder. This chronic adrenaline causes further cell death. Beta blockers block those receptors, resting the heart and allowing the myocytes to potentially recover and remodel over time.
So ACE inhibitors open the pipes, and beta blockers shield the muscle from toxic adrenaline. But eventually, you need to increase the actual squeeze. You need to give the rubber band some tension.
For that, we use specialized drugs called inotropes. Dobutamine is a common intravenous option that directly stimulates the heart to contract harder. But a very specific, highly crucial drug utilized heavily in pediatric DCM is milrinone.
What makes milrinone so special? How does it work?
Milrinone is a phosphodiesterase inhibitor. It is a brilliant piece of pharmacology because it tackles the failure from two sides simultaneously. First, it works directly inside the cardiac muscle cells by inhibiting an enzyme that breaks down cyclic AMP.
Well, what does that do?
This ultimately vastly increases the availability of calcium inside the cell precisely during the moment of contraction. More intracellular calcium means the actin and myosin filaments can grip each other tighter, creating a much stronger, more forceful squeeze. It artificially gives the rubber band its snapback.
And the second effect?
Crucially, melanin also acts as a potent vasodilator, particularly in the pulmonary vascular bed and the systemic arteries. So, in a single intravenous drug, you are simultaneously significantly increasing the physical strength of the pump while aggressively lowering the resistance it has to pump against.
That's a powerful combination.
It is an incredibly effective, life-sustaining continuous therapy, often used as a bridge to transplant, keeping these children alive while they wait on the list for a donor heart.
Wow, okay, let's pull all of this immense pathology together. We have covered an extraordinary amount of medical ground today, peering into the absolute most vulnerable moments of human biology. We started with the fiery acute systemic vascular inflammation of Kawasaki disease. We explored how a mysterious unknown trigger and a misdirected immune response can deploy molecular scissors to actively dissolve the internal elastic lamina of a toddler's coronary arteries in a matter of days.
A literal race against time to extinguish the fire with pooled antibodies and high-dose aspirin before the aneurysms burst.
From there, we navigated the dangerous, genetically overgrown muscular blockades of hypertrophic cardiomyopathy, picturing that massive bouncer completely blocking the left ventricular exit door, and exploring the high-stakes risk stratification that determines who gets an internal defibrillator. We traveled to the equatorial tropics of Nigeria and Uganda to explore the stiffening geographic mystery of endomyocardial fibrosis, the toxic potential of cerium-laced cassava, turning the heart into unyielding concrete, leaving behind the tragic heart of Africa sign on an X-ray.
And we ended by understanding the exhausted, stretched, failing rubber band of dilated cardiomyopathy, where the muscle simply loses its snap due to viruses, chemotherapy toxins, or genetics, requiring a delicate pharmacological balancing act just to keep the blood moving.
It has been a profound, microscopic journey through the pathology of the heart.
It truly is. And if we connect all of this intense medical detail back to you, the listener, understanding these conditions isn't just about memorizing diagnostic criteria or the precise dosages of milrinone. It is about fundamentally recognizing the profound, delicate, almost impossible engineering of the human heart.
It really makes you realize that it's an absolute miracle the system works at all.
It is the ultimate testament to biological resilience. We take completely for granted that this specific muscle, this localized collection of sarcomeres and electrical pathways, will contract and relax perfectly over 100,000 times a day, every single day, for 80 years without us ever having to consciously think about it.
It's staggering.
But as we've seen today, a single microscopic genetic typo in a myosin protein, a localized abundance of a rare earth metal in the soil, or a sudden, misdirected immune response to a common childhood cold virus is all it takes to bring the entire elegant system crashing down. It deeply emphasizes the absolute miracle that, for the vast majority of us, it functions perfectly, silently, for decades.
It really makes you appreciate the baseline of health in a whole new way. As we wrap up this incredibly detailed deep dive, I want to leave you with one final lingering thought. Think back to the endomyocardial fibrosis mystery. We discussed the actively researched hypothesis that high concentrations of a rare earth element, cerium, existing naturally in the soil, absorbed into the cassava plants that young children eat for survival every single day, could physically alter the cellular pathways and stiffen the structure of a child's heart into concrete. It is a chilling, profound concept.
It speaks to the intimate, inescapable, and often invisible connection between our immediate physical environment and our internal biology. We're quite literally built from the ground we stand on.
Exactly. So, if the very earth we grow our food in has the potential to shape our internal organs in such profound, localized, and devastating ways, what other invisible, hyperlocal environmental factors, elements in the soil, the water, the air, are quietly, currently writing the medical destinies of communities around the globe right now, just waiting for us to discover the link?
A phenomenal, vital question for the next generation of medical researchers to ponder.
And with that, we want to thank you for bringing your deep curiosity, your attention, and your time to this exploration. We hope we've helped clear up some of those diagnostic muddy waters we started with and given you a new appreciation for the engine keeping you alive. Keep questioning, keep learning, and we'll catch you on the next deep dive.